Every cell in your body requires a steady stream of oxygen in order to function. The respiratory system is responsible for bringing oxygen into the body and getting rid of the carbon dioxide that cells produce when they use oxygen. In this chapter, you will learn how the respiratory system provides your body with the oxygen that is vital to life. Since the respiratory system brings oxygen from the air into the body, it is wide open to all elements in the air, including airborne pathogens. As a result, the respiratory system is especially susceptible to infectious diseases. This explains why some of the most frequent ailments that healthcare professionals are likely to encounter are respiratory disorders, like laryngitis, bronchitis, influenza, and the common cold. In order to assess and treat these patients, you must first understand the various components of the respiratory system and how they function. For example, knowing that the nasal mucosa is continuous with the mucosa of the respiratory tract allows you to predict the typical progress of the common cold, with symptoms first affecting the nose and nasal passages, then moving to the throat, and finally ending with symptoms affecting the chest, like coughing. By having a solid understanding of the anatomy and physiology of the respiratory system, you will be able to properly treat your patients who exhibit symptoms of the common cold and other respiratory disorders.
We all know that the respiratory system, we take a breath, we bring in oxygen from the air, and then when we exhale, we release carbon dioxide into the air. And we usually think of this on a big scheme, right? We think about ourselves, keeping the organism alive. But in fact, that oxygen has a goal to get into each and every one of our trillions of cells. And inside those cells, almost all of them except red blood cells have mitochondria, and more than just one. A skeletal muscle has so many. So the oxygen is what makes us have ATP and glucose. You must have glucose, you must have oxygen to make ATP. And then, as you learned in nutrition, 10 million ATP molecules per second per cell. So that just shows you how important the respiratory system is. That's a lot. Now, that oxygen isn't going to get anywhere without our circulatory system, right? When we breathe in that oxygen, it has to be picked up by the circulatory system. So they're closely linked. And if one of them fails, they're both going to fail. And that's the major purpose of the respiratory system. Get some oxygen into the blood, into our cells. It also helps us smell, right? Our nose is part of the respiratory system, and we can smell. And it also, the larynx has our voice box, so it helps us with speech and makes the voice that you determine, hey, that's such and such's voice. They have a very unique voice, I can tell, because of their larynx, which is part of the respiratory system. So a couple of things to memorize. The term pulmonary ventilation is breathing. So the idea of ventilation, being put on a ventilator, is moving air in and out of the lungs. So that's a memorization thing. Another one is this external respiration. So when we take in that oxygen from the air and we blow it out from the carbon dioxide out into the environment, that oxygen has to get into our little capillaries. And the carbon dioxide has to go from the capillaries into the lungs. That's external respiration. So external respiration is between blood and lungs. And then, of course, if we have an external, then we have to have an internal respiration. And that's where that blood has picked up that oxygen and it's going to go and bring it to a cell. So when you have that oxygen exchanging not between the blood and the lungs, but rather between the blood and the cells, and carbon dioxide going from the cells into the blood, that's internal respiration. That happens at the circulatory system. So respiratory system, external respiration, circulatory system, internal respiration, and the difference is where the gases are exchanged. This picture is showing that how these two things are interrelated. This picture right here. Oh, my little pointer's gone. Sad. Ugh, computers. All right, well, this right here is showing a capillary bed. So great vessels coming, let's say the artery coming off of the heart, bringing oxygen to your cells, systemic circulation. Here's another one. This is the capillary bed down here. They're both capillary beds. One of them is in the systemic system and one of them is in the pulmonic system. Where the vessel gets the tiniest, you start big, they slowly get smaller. You've got a gazillion of these capillary beds. So sad about not having a pointer. What the heck? And that's where exchange happens. Do you remember AMP1, simple squamous? The purpose of simple squamous was for diffusion, for simple diffusion. So you can just exchange molecules if they're small enough to get through it. I'm flipping through my lab book here, going to whatever chapter that was, what exercise that was. Absorption of materials and the important body sites, capillary walls, and air sacs of lungs. How about that? So we have capillaries all over the place, not just at the lungs, like this is showing right here at the top, but also at the bottom. You've got lots and lots and lots of cells that need that oxygen. And so the tiniest little vessels are going to exchange that oxygen carbon dioxide through a capillary bed. Okay, functional anatomy. We have an upper and lower respiratory. Lower starts with the larynx. So that's where your voice box is housed. Upper is going to be your nose, sinuses, and your throat, your pharynx. Anything larynx and lower is lower respiratory infection. So the doctor says you have an upper respiratory infection, maybe a sinus infection, right? You could have an infection in your throat. But once it gets deeper, you get a tracheitis, bronchitis, laryngitis, itis, inflammation. So that's going to be in your lower airway, lower respiratory infection. If you get an infection in your lungs, that's going to be pneumonia. So here's a drawing of what the airway in general looks like. We've got to get into more detail in those lungs later. But you can see how, remember those little conchae on your nasal turbinates? They're on the ethmoid bone, remember that? You had two of them, and then you actually have one lower one that's a separate bone. But anyway, you have these mucous membranes that go across that in your nasal cavity, and that is increasing the surface area in your nose, and it's going to help moisturize the air that comes in. It's going to help, we've got hairs in there, it's going to help catch the cooties that are coming in, the dust, the wind, hopefully little things that you can sneeze back out. But of course, also, this is a great place for the common cold to set up house and invade and get into these cells and start their replication. Remember, the pharynx is a shared area. So the pharynx is both respiratory and gastrointestinal. The larynx is this top part right here where you're housing your voice box. So it is the most superior part sitting on top of the trachea. Then, of course, we've got a left and a right side, so that trachea is going to separate into two main or primary bronchi, and then those are going to separate into secondary and tertiary, blah, 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 blah. This guy right here is the main player of respiration. The diaphragm, along with your external intercostal muscles, they're the guys that help you take a breath. I already said a couple of these. This nose is going to bring in some air and warm it and moisten it. The hairs in there are going to capture it, filter out the dust, pollens, if you're from Louisiana, mosquitoes and gnats, whatever. And so it helps keep those kind of things from getting down into your lungs. Also, if you've been outside when it's really, 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 really cold and you felt the burn, you've zapped your nasal passageways with cold air and kind of instantly dried them out. They want the air that goes down to the lungs to be moist. That's their job. So it kicks into overtime, and maybe you start to get a runny nose because they're like, wow, that's cold, whatever. We don't think very much about how important our nose and our sinuses are for our speech. But Willie Nelson, if you don't know who Willie Nelson is, look him up, listen to his voice, and you can't say that he doesn't have a unique singing voice. And then, of course, the nose, cranial nerve 1, has these tiny little branches, just threads coming off of the olfactory nerve, embedded in the mucous membranes of our nose so that we can smell. There it goes. Okay. So we have the external nose, the part that you actually see. It's got the nostrils that are called nares, memorization term. The nasal cavity is inside the nose, the part of that you can see, and there's actually a nasal septum that's supposed to be midline, dividing left and right. People that get sinus problems, they might have a deviated septum, and so they maybe don't drain their sinuses well, more prone to sinus infections. Or you could be born that way, or you could have gotten a broken nose. I've mentioned this before, how mucous membranes don't just produce mucus. We've all gotten a runny nose without snot. So these mucous membranes are going to be producing mucus from the mucoid cells, from the mucus cells, and then this watery fluid is from serous cells. These discharges that we have actually can secrete enzymes that can help break down bacteria, and also, not just physically protect us from those kind of things getting down into our lungs, but actually does a good job of an innate, so a born with defense to try and kill those routine bacteria that get into our nasal passageways. You remember that our respiratory system, for the most part, is going to be pseudostratified ciliated columnar once we get down into that trachea. And those little hairs are actually an elevator. They're called a mucociliary elevator that are always sweeping upward to try and get any contaminant towards the throat. And then once it's in the pharynx, you swallow it. And then, of course, it's going to go into that hydrochloric acid and die. That's the goal. Our nose actually is loaded with tiny, tiny, tiny little capillaries, lots of them. So, you know, if you get nosebleeds or if you've ever been bonked in the nose, how bloody that can be. It looks like you're going to die sometimes. And it's just because it's so vascular. The head in general is very vascular. The littlest nick on the scalp makes people go to the ER because they think they're going to bleed to death, when in fact it's just because there's so many vessels to bleed. It could be a pretty small boo-boo. Lots of nerve endings, and we all know that, right? So the purpose of that is so that you can feel that tickle when you get something in your nose, like the mosquito tickles you and you want to sneeze it out, right? I mean, that is, you know, if you haven't been fishing in the swamps of Louisiana, you might not know what I'm talking about. But when that little mosquito or that little gnat makes it into the hairs of your nose and tickles you, you don't care if you have Kleenex. You're blowing. Okay. So those little scrolls that I've mentioned before, you saw them in A&P1. The more superior and the middle one are part of the ethmoid bone. Then you actually have an inferior conchae that's a totally separate bone. And that shape is increasing surface area. So the way that it is allows for more mucous membranes and more hairs to capture these things. Also, it creates turbulence so that that air that you breathe in can actually kind of swirl around in your nose to get moistened, to capture any sort of cooties, to get warmed and humidified before it goes down into your lungs. So here's a visual of those conchae, the upper, so superior, middle, and inferior conchae. The little dips area are called a meatus. And what else is on this slide? Oh, there's the sphenoid sinus for you to see. Don't worry about the posterior nasal aperture. But looky here, that cribriform plate of the ethmoid bone, what passes through that? Cranial nerve 1 endings are going to go down into that mucous membrane where we have receptors so that you can smell. It's the only sensory pathway that doesn't stop off at the thalamus. Do you remember that? All the other guys, sensory relays got to stop off at the thalamus. Not smell. It's going straight to your brain. Itis, inflammation of. Rhinitis is inflammation of the nasal mucosa. Sinusitis is inflammation of the sinuses. Now here's the problem with that. When your sinuses get inflamed, what'll happen is that passageway that's going from your nose into your sinuses is swollen. So you take a breath in, you're using pressure to pull that air in, and then so that's an active process. You work on that. When you exhale, that's just relaxing. Well, when you take a breath in and your sinuses are swollen, you forced air past those swollen mucous membranes, but now it's trapped. When you exhale, the mucous membranes are swollen. So when you take a breath in, you force that air in. When you exhale, you still have all that air stuck in your sinuses. What's going to happen? A headache. It's a pressure headache because that's all been created. You've made a vacuum with that. Well, you didn't, but whatever caused the inflammation of the mucous membranes in your sinuses, you can force the air in, can't go out. Boom. That's a lot of pressure. I don't think there's anything really new on this slide that you need to know. The pharynx is your throat, your shared area between your digestive system and your respiratory system. And I've already mentioned the three regions, the nasopharynx, the oropharynx, and the laryngopharynx. We don't want any food up in that nasopharynx, but obviously air passes through that just fine. We're going to have some tonsils again that I'm going to point out better this time. I could show you the palatine tonsils in the digestive system, and I could show you the lingual tonsils in the digestive system. But the nasopharynx is where the pharyngeal tonsils, maybe you've heard them called adenoids, that's where those guys are. So with my little lack of pointer, whatever, see if I can get this guy to work up here. Are those adenoids, those pharyngeal tonsils are up there. Do you remember? Give my little pointer here. Palatine tonsils. And then I've kind of covered up the lingual tonsils, which are at the base of the tongue right there. Oh, look, even better picture. Okay, study this one. Okay, so now we're going to move on to the lower respiratory system. There's two zones of the lower respiratory system. So the conducting zone is still doing kind of the same thing that your upper respiratory system does. We're still going to have those. We have some cilia. They're going to be capturing cooties. So hopefully trying to keep things from getting down to the depths of our lungs where we exchange air at the alveoli. Again, you met them in AMP1. It's going to help warm the air and humidify the air. And this conducting zone is going to stop at bronchi. So we have primary bronchi, secondary bronchi, tertiary bronchi. We're going to, and they go down tinier, but we don't name anything past that. Tiny little branches until they get really small. And that's when we switch over to the respiratory zone, because this is where we're going to exchange gas. So obviously, if we're going to exchange gas, they'd have to be pretty stinking small. The respiratory zone is going to be these little respiratory bronchioles, alveolar ducts, and alveoli. We'll look at those in a minute, but right now we're going to look at the larynx, your voice box. It is an open airway, so patent is open, going to the trachea. He has the epiglottis, remember, so that when you swallow your food, the larynx kind of elevates up. The epiglottis will lay on top of it and make sure that your food goes down your esophagus. And then finally, the voice box, your vocal folds, are actually on the most deep part of your larynx. We have some cartilages that I want to point out because you do need to know these for your lab. The biggie, the one that you think of as a man's Adam's apple, the one that you actually can touch, even if you're a girl, you can touch it, but a man's is more pronounced because of testosterone. That guy is called the thyroid cartilage. Now, underneath the thyroid cartilage is a ring-shaped cartilage, and it's called the cricoid cartilage. Most of the rings of the trachea they're C-shaped. They're not complete, but this cricoid cartilage goes all the way around as a circle. So he's unique. You should be able to recognize the epiglottis, where it comes and lays on top of the airway so food doesn't go down your airway. Arytenoid cartilages are actually holding on to those vocal folds, and I don't want you to memorize that, but I'm going to point them out. You would use those guys to help you put in a trach tube. AP1, where do we have elastic cartilage? Epiglottis and the ear, elastic cartilage. Most of our cartilage is hyaline, and actually in the tissues lab in AMP1, you looked at the rings of the trachea. So this is showing, no pointer. I'll try this little pen here. Maybe you can see that little dot. This right here is the most anterior part of the thyroid cartilage right here. Underneath it, there's a cricoid cartilage. I would not ask you to identify any of this. But this is fair game. So remember that bone that was always broken on Mr. Bones? Or maybe dangling. It's actually not attached to any bone. It has lots of ligaments that kind of suspend it. So that's why it's kind of wired onto Mr. Bones, if it's there at all and nobody has pulled it off. Here is the thyroid cartilage right there. That's the thyroid cartilage. And here's the cricoid cartilage immediately inferior to it. This is the one that I was saying is the ring. He goes all the way around. Vocal folds are going to vibrate to produce sounds. As we grow, those folds are going to lengthen. And actually, these guys, these vocal folds, are definitely influenced by puberty in boys, and you can tell it, right? So I'm telling you, they're going to get thicker, they're going to get longer as we grow, and testosterone is going to make them more thick and more long than a girl's. But the body's not used to that yet, and so the nervous system is still adjusting to that rapid growth, and so the voice kind of cracks. But boys all figure it out, right? Let's see, they look white. They all these things, they're ligaments. Remember from AMP1 in the tissue section, ligaments do not have any visible blood vessels that are passing through it. They get their blood supply from vessels that are passing around it, but not when you cut through that tissue. Just like epithelium, there's no blood vessels when you look at straight epithelium, but there's some underneath it in the connective tissue underneath it. The term glottis is actually the opening between those vocal folds. So this is a very good picture to memorize for lab. You can see the thyroid cartilage from the side now. You can see the cricoid cartilage, how it goes all the way around. And of course, remember this has got a sagittal cut, a mid-sagittal cut, and you can see that it's going all the way around. Here's this picture right here that is showing an open and closed vocal folds. So when you're putting in a trach tube, this is actually what you'll be looking for. Cool picture, not a lab test question. This is showing a couple of different things right here. So you can do a cricothyrotomy temporarily to help get you through an emergency situation. A tracheostomy is going to be at least semi-permanent until they can do whatever they need to do on a more permanent basis. But you got somebody choking and they need air now. you're going to do a cricothyrotomy and hopefully get them through that crisis till you can get whatever is in the back of their pharynx dislodged. So the larynx, do you remember I mentioned the Valsalva maneuver in defecation? What you're doing is you are holding your breath and putting that epiglottis to cover the larynx. The glottis is going to close. With that increase in abdominal pressure, poop comes out. And so we actually use the larynx for increasing abdominal pressure. Another example would be like if you're going to tighten up your abs, boys do this funny thing where they like to throw punches at each other's bellies. What are you going to do? You're going to try and tighten up your abs. How are you going to do that? You're going to close up that glottis and increase abdominal pressure to do your best to tighten up those muscles so that maybe it doesn't hurt so bad, that fist or whatever boys do doesn't sink deeper into your belly and actually knock the wind out of you. That's the goal. Laryngitis. Itis, inflammation of larynx, voice box. So inflammation of those vocal folds that makes your voice hoarse or maybe even non-existent. Often it's caused by a virus, but it can be overuse, right? Football season. If you like football and you're you feel like you are the reason that your football team is going to win because you need to yell louder, perhaps you have suffered from laryngitis. Underneath the larynx, we have the actual airway, that pipe, the windpipe. You can feel it. You can push on it at the just above your the V in your neck. It's flexible. You already know this. Mucus lined because you saw goblet cells inside that ciliated pseudostratified columnar epithelium. The reason that those cartilage rings are C-shaped is because that esophagus runs down the posterior side of it. So when you swallow your food, especially if you didn't chew it up very good or you take really big bites, when you swallow, that big bolus is going down through your chest towards your stomach. You have to have a little bit of stretch in the esophagus. Well, if the back side, the posterior side of the trachea was a complete C-ring, you're more likely for that food to get hung up and for you to feel that lump in your throat or even choke. So here's a picture showing posteriorly the esophagus, anteriorly a cross-section through the trachea. You can see the cartilage ring with its hyaline cartilage, a very beautiful histology slide, I think. And then the pseudostratified ciliated columnar. You can see that on the most deep part right there by the lumen. And then, of course, you go below it, and then you have the connective tissue with the vessels, blah, blah, blah. Adventitia. Why do we call it adventitia? Well, if you were in the abdomen, you would call it serosa. And you would call it, whatever, peritoneum. The pleural cavity is for the lungs. So visceral pleura, parietal pleura, that has to do with the compartment that's taking care of the lungs. There's actually not really a serous membrane per se on the outside of this trachea or the esophagus for that matter. So that outer part, instead of calling it a serosal layer, we're going to call it adventitia. Do you remember this? Smoking. What happens with smoking? It destroys those cilia. So then we have lost our little elevator that brings all the little cooties that we breathe in back up into our pharynx so we can swallow it. And you develop a cough. We're trying to keep any mucus that's being made by the pseudostratified ciliated columnar epithelium from getting down into the lungs. So they cough. Plus all the cooties that did get down there. Fortunately, it is an epithelium. So if you stop smoking, then that epithelium will regenerate and you will have some very pretty little pseudostratified ciliated columnar epithelium to help with the elevation of those kind of things. The Heimlich maneuver was created by a gentleman named Heimlich. Incidentally, somebody used it on him fairly recently in the past couple of years to save his life. 97 years old, I believe, eating in a restaurant. And it was the first time he ever had needed that actual procedure. I hope you and I never need that done to us. But anyway, it did save his life. So what a lucky man he was. And the purpose of that, you are decreasing the volume inside of the abdomen, and so you're forcing air out of the trachea. I have a video. You do have to learn how to do this right, by the way, because you can crack ribs. Okay, so we have that trachea. It's going to divide into left and right sides, and you're going to have the primary bronchi. We're still in the conducting zone, right? Because I'm still saying bronchial. So we're still in the conducting zone until we get to little teeny tiny bronchioles. The right main bronchus is wider because we have 3 lobes on the right side. The left lung only has 2 lobes. The heart is moving towards the left, so we have this cardiac notch. All these things are making that right bronchus larger and straighter than the left. So when we get aspiration pneumonia or a foreign object, it very often likes to go to the right side. Then after you have the main bronchus going from the left to the right, it has to divide to go to each of the lobes, right? So if the left lung, I'm just telling you, has 2 lobes, then you're going to have 2 secondary bronchi. And on the right, I said that we have 3 lobes, so we're going to have 3 secondary bronchi. As we go further and further down, these little rings are going to become less ring-like, and they're going to be more plate-like, still hyaline cartilage. After we have gone to each of the lobes, we're going to divide again, and that's going to be tertiary bronchi, which are going to divide a whole lot. They're not going to do names anymore past tertiary, but once we get to the tiny, tiny, tiny tubules where you've had enough division that little passageway is less than 1 millimeter, that is going to be a bronchiole. And the bronchiole is going to be the beginning of the respiratory zone. So the tiniest of all bronchioles is going to be the terminal bronchiole. Have a picture here in a second. But it's going to be like if you think of going to the grocery store, you bought a cluster of grapes. That top part of a specific cluster of grapes, so not the whole, that would be still a bronchiole, not the whole cluster, but as you look at your cluster of grapes and you have a little stem that's going off to about 5 grapes, and then there's another little stem that's going off to about 5 grapes, The little stem that's going to those grapes is going to be the terminal bronchiole. Picture. Once we get into those bronchioles that less than a millimeter, we're going to have elastic fibers, right? Because when you take a breath, of course, your lungs expand, right? And then when you stop breathing in, they're going to collapse down. So we need some elastic fibers now. We don't need rings of cartilage. If something has made it this far, that's not good, but that's not this guy's job. At this point, when we're at bronchioles, our job is to exchange air into the circulatory system. We're going to have some smooth muscles. This is the reason when you have asthma, and maybe it's whatever pollen related, and you start to feel your airway tighten, those smooth muscles are spasming in response to an abnormal reaction to a pollen. Or maybe it's exercise induced. It's the smooth muscle spasming. When you take a bronchodilator, you are allowing those smooth muscles to not constrict, but rather relax to help bring more air into the depths of your lungs. So, respiratory zone is going to start with those respiratory bronchioles, and then we're going to have alveolar ducts going into each of the grapes. So, I'm saying that you're going to have the end of the bronchiole, the respiratory bronchiole is the part that's going into each grape cluster, and then the little stick that's going into each grape is the alveolar duct. The grape is the alveolus, the alveolar sac. We have so many alveoli. They're actually connected by little pores, and I'll show you a picture of that. Don't memorize this, but 300 million alveoli. And this is where you have that simple squamous that you saw in AMP1. You should be able to still identify the lungs under a microscope for your lab. This is where we're going to have gas exchange. So here's a picture of the grape thing that I was talking about. So terminal bronchiole would be like the stem that's at the top of the whole grape cluster that you just bought. But you know, there's little separations of grapes that, okay, here I've got 4 kids, so I'm going to pinch off pieces of my big grape cluster. Here you get to have this little cluster, you get to have this little cluster, you get to have this little cluster. The top of the stem of the little clusters is the respiratory bronchiole, where we're going to begin gas exchange. And then we have those little grapes dangling off of it. That's the alveoli. For your lab, I would definitely say be able to identify terminal bronchiole, respiratory bronchiole, and the alveoli itself. Picture hopefully looks familiar. So here is an alveolus, and we've got these little holes right here. Those holes are pores, and why would that be? If one of these guys has a little bit of fluid in him, try this red, has a little bit of fluid in him, well, at least I'm buddied up and connected to some other alveoli to help me exchange air. I might not be doing a great job, but I'm at least helping some. Here's a cool thing. Most of the time, when we say we're doing oxygen and carbon dioxide exchange between cells, there is the tiniest little tissue space. So you have that capillary. The oxygen is going to leave the capillary, go into the tissue, and then go into the cell. It's a minuscule space. But At the respiratory membrane, the capillary wall and the alveolar wall are essentially fused together. There is not a tissue space between the two. And so we can very easily get simple diffusion through both of those tissues lickety-split. And I would say it's probably the most important place to have lickety-split diffusion, wouldn't you? So simple squamous. The simple squamous, now we're going to give it a new name. It is still simple squamous, but more specifically, the cells that are doing that exchange are type 1 alveolar cells. Why is that important? Because here and there, throughout those alveolar sacs, we have a type 2 alveolar cell. He's making something called surfactant. Surfactant is going to break surface tension so that you can take a good breath. Infants that were born before 32 weeks of age aren't making this yet. And so if you had children a while ago, like me, my oldest daughter was born at 31 weeks, she hadn't started making surfactant yet. And there was no such thing as artificial surfactant yet. So that baby ended up getting put on a ventilator because she couldn't inflate her lungs. She didn't have surfactant to break the surface tension to allow those little sacs to stay open. They collapsed on themselves. Now they actually have artificial surfactant, and that is a game changer for neonatal care. So of course, elastic fibers, because the lungs are constantly getting big, going down, getting big, going down. And of course, if we need to exchange air, we have a lot of capillaries. Here's those alveolar pores giving alternative routes of air exchange in case part of an alveolus gets blocked. It also helps equalize air pressure throughout the lungs. So you're not going to have one area of lungs that's going to collapse all the time. A third kind of cell that I want to tell you about besides the type 1 and type 2 are macrophages. We love macrophages. They help keep us clean. They're the cleanup crew. We should always respect the janitoring system, the cleanup system. So these guys are constantly eating anything that made it past those cilia and got down into our lungs. And what's going to happen is they're going to eat anything. They're eventually going to get moved. They're going to die. Macrophages die. They do their job. The lysosomes kill whatever they ate, but unfortunately macrophages are going to get killed too. But it's okay because we have a mucociliary elevator that's going to bring them up to the pharynx and we're going to swallow them. Don't memorize that number, but look at that. 2 million dead an hour we're swallowing. That's a bunch. Fantastically beautiful picture. And this is showing how right here we have both the fusion of the basement membranes of the capillary and the alveolus. There is no tissue space. They're fused to allow for the best gas exchange. All right, gross anatomy of the lungs. I've actually already alluded to lots of these things. The hilum is on the medial surface of the lungs, mediastinal surface. That was actually in A&P1, we kind of skipped the mediastinum, but it's the medial section of the thorax. And at the hilum, we're going to have the vessels and the bronchi. We have, of course, whenever we have vessels, you should think arterial, venous, nervous system, lymphatic. They're all buddies. The left lung has 2 lobes, so a superior and inferior lobe. I mentioned that cardiac notch because we have to put our heart in there, right? Then we have the right side, so superior, middle, and inferior lobe. And I've already mentioned that the primary right bronchus is wider and straighter. So therefore, it is the area that we're more likely to get aspiration pneumonia, and foreign objects are going to get lodged up higher. Pneumonia is when things make it past, like the peanut that you accidentally inhaled when you were giggling and laughing, eating your kung pao chicken, and then the peanut made it past all that and got settled down into the depths of your airway. This is bad. That's a foreign object creating a response. Your immune system is trying to destroy that peanut, but it's awfully big. Aspiration pneumonia. Initially, I skipped over this picture. I had said picture, but I stopped, went back, and I want to point out something here. So here is a rib. So I'm at the chest wall. The deeper side of the chest wall has that parietal pleura, right? The underside of your ribs, your thoracic cavity, is lined with parietal pleura. Then your lung has visceral pleura. And then we have this little slit right here. Both pleura are releasing serous fluid to reduce friction. This makes it look like there's a big old gap. There is not. There shouldn't be. It's put like this so that you can see that there's a difference between the two, but in fact, they are right smack dab next to each other. So much so that when you take a breath, because of surface tension, we're not talking about alveoli right now. We're talking about the thoracic cavity, the pleural space here. Both the pleura, the parietal and the viscera, are making fluid. Surface tension makes that parietal pleura kind of cling to the visceral pleura. So they're buddies. There is a space there, but there's usually nothing in there except the tiniest bit of serous fluid, which is mostly water. And then we've got those hydrogen bonds. And they're going to be grabbing a hold of each other. When you take a breath, your diaphragm goes flat and your ribs go out and up. Your parietal pleura is actually clinging to your visceral pleura, and that actually helps those lungs expand because they're buddies. They're attracted to each other by hydrogen bonds. That's probably more information than you ever wanted to remember, but we can't forget, we taught you the basics of chemistry and left all the details out, and there's a reason. We picked out the most important things that you need to keep remembering. Sorry. Beautiful picture again, transverse cut. So pleural fluid is minimal. It's there to reduce friction. It's there between the two pleura, but they actually help those lungs expand because they're attracted to each other. Pleurisy would be another name for pleuritis. Itis, inflammation of. Pleurisy, pleura, is very painful. Whenever you have inflammation, that nice, glistening, smooth tissue starts getting rough. It almost even kind of looks like, same thing with peritoneum, looks like it has these tiny little skin tags on it. Very, very owie to take a breath. Very. Other things can gather in the pleural cavity, none of which you want. When something builds in that pleural cavity, it's called pleural effusion. So that's the general term. Then you have to find out, so you take an x-ray, you can see fluid surrounding your lungs. This is different from pneumonia. Pneumonia is fluid inside the alveoli. This is inside the pleural space, so it's called pleural effusion. When you take an x-ray, you can't tell if that's blood, if that's serum, if that is some sort of transudate, or if it's pus. You can't see that. You just see the fluid. So you'd have to tap the fluid, get a sample of the fluid, and find out what it is. Blood could be from any sort of trauma. It could be a tumor, which is pretty uncommon in that space, but it could happen. Blood filtrate would be from pressure, so just like with the liver, if the liver gets cirrhotic and scarred and it's hard for blood to pass through it, you start to have fluid built up in the pleural space if you have some sort of problem with the drainage system, if you will, like with a tumor. That's probably going to be more of a serous type buildup. Left-sided heart failure. When you have a water pump that breaks, the water builds up behind the water pump. Well, that's essentially what's happening with left-sided heart failure. You can start to get problems with the capillaries starting to ooze serum into that space. Pus, purulent is the right term for pus. So on a chart, you don't put pussy fluid, you put purulent fluid.